Welcome to Cardiovascular Disorders Part 2. Today we're going to talk about disorders of the heart. You'll want to review the normal coronary circulation. Now we're going to talk about coronary artery disease. They are divided into two disorders, the acute disorders and the chronic disorders. Acute disorders include unstable angina and myocardial infarction, and these are due to acute ruptures of plaque. And then the chronic ischemic disease includes stable angina, vasospasm, or stable plaque. Okay, so let's look at those plaques. So stable plaques, those are the atherosclerotic lesions that have thick fibrous caps, and you can see they partially occlude the blood vessels, but they're stable and they don't tend to form clots or emboli. So if this plaque was in a coronary artery and you had increased demand for oxygen, such as with exercise, which could just be walking the stairs, then you may not get enough oxygen because of this stable plaque here, and that would be called stable angina. And then if you rested, or you took nitroglycerin, which causes vasodilation, or rested, which would reduce the demands of the heart for oxygen, then that chest pain would lessen because the angina was stable. Unstable plaques, on the other hand, have thin fibrous caps. And then if they rupture, that can cause sudden platelet adhesion, aggregation, and the formation of a blood clot or thrombus. So these would result in the acute coronary syndromes, kind of going from most mild to most severe here. Unstable angina, which could proceed to a non-ST segment elevation MI, in which we have mostly occluded but not completely occluded, and this can result in a heart attack of part of the thickness of the wall. Or we can have a ST segment elevation MI, which involves myocardial infarction of the full thickness of the heart wall. Okay, so the chronic ischemic heart diseases are essentially the result of myocardial ischemia, when we have an imbalance between the blood supply and the demands of the heart for oxygenated blood. This is usually due to atherosclerosis, but may also be due to vasospasm, or a combination of atherosclerosis and vasospasm. And there's three different types that we'll look at now. Chronic stable angina is when we have chest pain or pressure that's associated with a transient myocardial ischemia as a result of a fixed obstruction due to a stable plaque. So this is when we have increased demand, and we're trying to get blood flow around a stable plaque, and this is going to result in a transient myocardial ischemia that is precipitated by increased demand of the heart. So with physical exertion, this can also include stress and exposure to the cold. Now, permanent damage usually does not occur because we would decrease the demands, we would rest and stop, because permanent damage doesn't usually occur unless that ischemia occurs for a really long period of time, say greater than 20 to 40 minutes. And this pain, like I mentioned, can be relieved with rest, because that's going to decrease the demand, or with nitroglycerin, which is going to cause vasodilation of the coronary arteries to increase the blood flow. Okay, stable angina is going to result in recurrent, intermittent but brief, so usually about 3 to 5 minute episodes of substernal chest pain. It can include tightness or pressure that may radiate to the neck and the left arm. It can include pallor, diaphoresis, sweating, and shortness of breath. The key here is that this type of pain is recurrent, and it's brief, and it goes away with rest or nitroglycerin. Silent myocardial ischemia occurs in the absence of angina pain. And this could be either due to really short ischemic periods that involve less tissue, or it may also occur in patients who have defects in pain threshold transmission, so they just don't feel it. Variant angina occurs when the coronary arteries constrict or spasm. And there's a variety of things that are thought to be involved, such as endothelial dysfunction or altered nitric oxide production. There are two types. There's the pure vasoplastic, and that's just simply vasospasm that occurs in coronary arteries that don't have plaque, without plaque. And then proximetal, and this is when we have vasospasm on top of plaque. So maybe you even had a site of stable angina, and then we get vasospasm that creates this variant type angina. This variant angina can occur at rest or with minimal exercise, and it often occurs between the hours of midnight and 8 a.m. This can lead to arrhythmias and sudden cardiac death, so this is also very important to keep on top of. Okay, so now we're going to look at the acute coronary syndromes. And remember, these occur when unstable plaque. So when we get a rupture of a plaque and the development of platelet aggregation and then the formation of a thrombus. And this can range from unstable angina to an acute myocardial infarction. Now, depending on which we have, unstable or myocardial infarction, this is determined on the basis of the EKG as well as serum cardiac markers. So essentially, if it's unstable angina, if the blood gets restored within about 20 minutes and necrosis of the cardiac myocytes doesn't occur, we'd also see no ST elevation. Acute myocardial infarction, on the other hand, occurs if blood flow is not restored in about 20 to 40 minutes. In this case, necrosis of the cardiac muscles cells occurs, and when you remember with necrosis, the cell contents are released into the extracellular space. So we would have the release of various enzymes, such as cardiac troponin, creatine kinase, and myoglobin, and then these things can be detected in the patient's blood, and that will confirm the diagnosis of myocardial infarction or heart attack. Then there are two types of myocardial infarction. There's the non-ST elevation MI, and in this one we do not see ST elevation on the EKG, and it does not involve the full thickness of the wall of the heart. And then with ST elevation myocardial infarction, we do see the ST elevation on the EKG, and we know that the full thickness of the myocardial wall has been affected. This is also referred to as a transmural heart attack. Okay, so how do we differentiate unstable angina or myocardial infarction from stable angina? So if we're considering unstable angina that could progress to myocardial infarction, we would define that pain as severe and being characterized of one or more of the following. It occurs at rest or with minimal exertion and lasts more than 20 minutes if it's untreated. It is severe and it is of new onset, like less than 1 month, as opposed to stable angina, which has already been detected and diagnosed. It is more severe, prolonged, or frequent than previously experienced. So unless we know what it is, any new onset angina should be considered unstable until it is proven otherwise. Now, if that myocardial ischemia is not reversed in unstable angina, this leads to myocardial infarction. So unstable angina and non-ST elevation myocardial infarction differ in whether the ischemia is severe enough to cause myocardial necrosis and the release of detectable serum enzymes. Non-ST elevation MI and ST elevation MI differ in ECG changes, so ST elevation or non-ST elevation, which reflect whether the injury was just subendocardial versus transmural injury across the whole thickness of the wall. Okay, how is this evaluated on the EKG? Unstable angina and non-ST elevation MI, we may see a normal ST or ST segment depression, shown here, depression, as well as T-wave changes. So the degree of this change, this deviation, is a reflection of the amount of ischemia. ST elevation MI, on the other hand, shows ST elevation. So here's the normal ST segment, and here it is elevated. Here it is elevated. And that indicates there's been necrosis of the myocardial tissue of the full thickness of the chamber wall. We can also see prominent, wide Q waves. Now, to determine, confirm that it was a myocardial infarction, we can look at those serum enzymes, okay, that were released from necrosis of cardiac myocytes. So what happens during an acute MI? So first, the heart muscle is deprived of oxygen. At first, the cells can switch to anaerobic glycolysis, but eventually this is going to result in electrolyte disturbances. That's going to start leading to a loss of contractile function. The heart is not going to beat as effectively. And then it can result in irreversible injury after about 20 to 40 minutes of ischemia. That leads to necrosis and the release of cardiac enzymes. Over time, that necrotic tissue gets replaced with scar tissue that the patient survives, which is non-contractile and is not able to contribute to the pumping efficiency of the heart. Okay, the size and the location of the infarct is going to depend on the location and extent of the occlusion. So it depends on which coronary artery is blocked and how much of the heart muscle that coronary artery supplies. About half of all myocardial infarctions occur due to occlusion of the left anterior descending coronary artery. This is called the widowmaker. Knowing changes in the ECG can help also to identify the location of the myocardial infarction. So if you do a full 12-lead EKG, you can help pinpoint the area of the heart that was involved. With a heart attack, immediate reperfusion therapy is usually indicated, and this can be used by giving drugs to break down the clots or coronary artery bypass grafts or other interventions. Okay, so is it unstable angina or a myocardial infarction? Well, angina causes pain, so does myocardial infarction. Angina can cause ST depressions. Non-ST elevation MI can also cause ST depression. But angina will not cause elevation in cardiac enzymes because the cells were not deprived of oxygen long enough to cause tissue necrosis. Both ST elevation MI and non-ST elevation MI will cause changes in cardiac enzymes. Now, about 15% of patients with unstable angina will progress to myocardial infarction, so it's very important to recognize and treat unstable angina. So what are some of the signs and symptoms of myocardial infarction? We have chest pain is classic, severe, crushing, constrictive. It can be radiating into the left arm or neck, or it can feel like heartburn. It is not relieved by rest or vasodilators. Sometimes it can be absent in the case of a silent MI. It can cause sudden shortness of breath, weakness and fatigue, GI distress, nausea, vomiting. Often in women, these are the main signs: GI distress, nausea, and vomiting. Tachycardia and vasoconstriction, which can cause pallor of the skin. Diaphoresis, not shown here. Anxiety, restlessness, a feeling of impending doom. Hypotension, because the heart is not pumping out efficiently, and that can lead to shock, cardiogenic shock. I do want to mention just again that a lot of these are kind of classic signs, but they can present very different, particularly in women. So a lot of times things like heartburn, or just even some of this sudden GI distress with shortness of breath, weakness, and fatigue are going to be treated like a myocardial infarction until shown otherwise. I have a link to some of the signs and symptoms of myocardial infarction in women. I encourage you to check that out. So what are some of the complications of a myocardial infarction? They can cause arrhythmia such as ventricular tachycardia or ventricular fibrillation. Mechanical, we can have ventricular failure. Too much of the heart muscle has been affected. Structural, we can have ruptures of the interventricular wall, of the free wall. Papillary muscles can rupture, and this is going to affect the functioning of the heart valves. Ruptures can lead to bleeding into the pericardium, which can cause cardiac tamponade. We can have pseudoaneurysm, this kind of bulging out of the ventricular wall here. Can also lead to cardiogenic shock. Okay, so what are some of the diagnostic tests that can be done? We can look at the EKG, looking for ST depression or ST elevation, prominent Q waves. Serum biomarkers, as I mentioned before, released from necrotic cells. So you have cardiac forms of troponin, and these will rise in the blood 3 hours to 7 to 10 days. Creatine kinase, 4 hours to 2 to 3 days. Myoglobin, 1 hour to 8 hours. This is not specific for cardiac muscle, where these other two are cardiac specific. So usually we look at all three and kind of compare them at different time points. Increased white blood cell count, elevated C-reactive protein, and an increased erythrocyte sedimentation rate. These are just general markers of inflammation. And then we may see changes in the blood gas in severe cases. Okay, so now we're going to look at disorders of the pericardium and disorders of the myocardium. So remember, the pericardium is the double-walled sac that surrounds the heart. Pericardial disorders can be classified by cause. Many are idiopathic, and then there's a few things that can be linked to that, idiopathic, such as infectious, autoimmune, metabolic, and so forth. They can be neoplastic or cancerous, or some are congenital. Okay, acute pericarditis. This is describes the signs and symptoms that result due to pericardial inflammation of less than 2 weeks. It's usually caused by a viral infection. Exudate is the inflammatory condition caused by increased capillary permeability. The manifestations of acute pericarditis include chest pain and fever. You can hear a friction rub, some EKG changes. Now, this inflammation of the pericardium may restrict the heart's movement due to that exudate. Filling the pericardial cavity, this is called pericardial effusion, so that exudate can press on the heart. Or we can also have fibrous scar tissue that makes the pericardium kind of stick to the heart and constricts it, and that's called constrictive pericarditis. Okay, so with pericardial effusion, we have fluid buildup in the pericardial cavity. This is going to restrict the expansion of the heart, so the heart cannot fill. And if it cannot fill enough, then we're going to have a decreased cardiac output, and that's going to lead to decreased blood pressure and shock. On the right side, if the right ventricle cannot fill with enough blood, there's going to be increased back pressure in the venous system, and this can lead to distension of the jugular veins. Now, if we get a large amount of fluid that builds up in a short period of time, this can result in cardiac tamponade. And this is where we have a large amount of fluid that rapidly accumulates that compresses the heart wall, So the heart cannot expand to fill. Blood backs up into the systemic circulation, like I said, leading to distension of the jugular veins. We have decreased blood flow to the lungs and decreased blood flow or blood output to the body. Some of the signs and symptoms are a change in blood pressure during expiration, so greater than 10 millimeters of mercury than during inspiration. And this is a reflection of the impairment of the left ventricular filling. Muffled heart sounds due to all that fluid buildup, severe dyspnea, and a dull chest pain. Okay, so that pulsus paradox is an exaggeration of the normal variation of the systolic blood pressure that occurs with respiration. So there's normally a variation that occurs with respiration, and that's because with a normal inspiration that draws in more blood to the right ventricle, and that compresses a little bit the left ventricle. So then on the next beat or output of the left ventricle, the blood pressure is lowered. So there's a greater exaggeration of that with tamponade. So with tamponade, on inhaling, the right ventricle fills with extra blood, but the heart cannot expand fully when the right ventricle is overfilled. So the left ventricle is compressed even more. And on the next heartbeat, the left ventricle does not send out as much blood, and therefore the cardiac output, and thus the systolic blood pressure drops. Okay, constrictive pericarditis is where we have scarring that causes the pleural membranes to adhere to each other. And this is going to encase the heart in a rigid shell, and that's going to compress the heart. It's not going to be able to full properly, and that's going to decrease the cardiac output. It's going to be characterized by a high venous pressure, because blood is going to backflow into the systemic circulation, a low cardiac output, a narrow pulse pressure, because that systolic blood pressure is going to be decreased, fluid retention, such as ascites, so fluid retention in the systemic circulation, Kussmaul's sign, which is where we have inspiratory distension of jugular veins, and this is going to be caused by an inability of the right heart to accommodate that increased venous return during inspiration. Okay, we're going to talk about a few arrhythmias and conduction disorders. Arrhythmias are a disorder of cardiac rhythm. They could be supraventricular, so above the ventricles, and those would originate in the SA node, the atria, the AV node, or the junctional tissues. Ventricular arrhythmias are going to originate in the ventricular conduction system and muscle. Conduction disorders is where we have a disruption of the flow of impulses through the conduction system, and this results in what is referred to as a heart block. Okay, if we have a sinus rhythm, that means it originated in the SA node. And so if we have a sinus rhythm, the rhythm is normal. We have normal P, QRS, T wave, but the rate may be varied. So normal P, QRS, but the cardiac cycle or rate is altered. With sinus tachycardia, the heart rate is greater than 100 beats per minute. Of course, with exercise, this is a normal response. With fight or flight, stress, anxiety, or anger. We can also see tachycardia due to fever, anxiety, caffeine, hyperthyroidism. It can be a compensation to help raise blood pressure, such as with decreased blood volume or with heart failure. It can be seen as a compensation in hypoxia or COPD or anemia. So once again, with sinus tachycardia, the signal originates in the SA node. It's a normal signal, but it's fast. Sinus bradycardia, the SA node is in control again, but the heart rate is slow, less than 60 beats per minute. This can be due to increased vagal tone, so increased tone by the vagus nerve. We can see this in hypothyroidism, in some diseases of the SA node, or this can be completely normal in a well-conditioned athlete who has a greater stroke volume at rest and thus can have a lower heart rate to maintain the same cardiac output. Okay, so here's a look at a normal sinus rhythm. I think it's about 60 or 70 beats per minute. Sinus tachycardia, and then sinus bradycardia. Okay, premature depolarizations. This is where we have some ectopic focus that could arise in the atrial muscle for premature atrial contraction, or ventricular muscle, or for premature ventricular contraction. And this is just a little area of the heart that's just a little bit irritable, and it spontaneously depolarizes, and it sends a wave of depolarization rather than having that wave of depolarization starting at the SA node. So here in the atrial one, we see a normal, and then here's an early one, and the P wave probably falls on top of that T wave, so it looks funny, we don't really see it. That came early. And then there's a little delayed response afterwards until the SA node then repolarizes and takes over as the pacemaker. And here's a normal one, a normal one, a normal one, here's an early one, and then once again there's a little delay afterwards, waiting for the SA node to take over again as the pacemaker. Premature ventricular contractions, they don't have a P wave, and the QRS is wider and bizarre. So here's a normal P, QRS, T, P, QRS, T, and then we get a premature ventricular contraction, and then a little bit of a delay, and then we're back to the normal EKG pattern. Now, with PVCs, this contraction occurs early, so it occurs before filling is complete. So it kind of results in a skipped beat. So if the heart doesn't fill all the way, then it's not going to pump as much blood, and sometimes I can feel it on myself sometimes as a missed pulse. The following beat, though, in this case it would be the subsequent beat. If you're feeling the pulse, you can't see, there's no indication of this on the EKG, but if you're feeling the pulse, the beat after the skip beat feels stronger because there's been a lot longer filling time. And so that's going to increase the end-diastolic volume, increase the stroke volume, increase the cardiac output. Now, these can be pretty normal. They occur in most normal individuals. Sometimes, caffeine, other stimulants can cause them. But they are pretty normal. But they do occur more commonly under abnormal conditions. Another thing that I got an increased amount of these during my pregnancies. I also tend to just have a lot of these. So finally I was having so many that I felt, I could perceive. I went to the doctor and they put me on a 48-hour Holter monitor. And during that 48 hours I had apparently 6,400 PVCs, which the cardiologist called unremarkable. So there you have it. Okay, however, we don't want to have a whole bunch of those in a row. So that can result in sudden atrial tachycardia or sudden ventricle tachycardia, depending on where it originated. Really rapid heart rate with atrial tachycardia or ventricular tachycardia. Now with ventricular tachycardia, this is life-threatening, okay, because the rate is so rapid. This is going to severely reduce the cardiac output. This may lead also to ventricular fibrillation, which is most likely is going to require being defibrillated, or can lead to sudden cardiac death. A variety of things can cause this. We can have myocardial scarring from a previous heart attack, reentrant arrhythmias, repolarization abnormalities such as long QT syndrome, drug toxicities, or electrolyte imbalances. Okay, we can also get to fibrillation. So with fibrillation, we have completely uncoordinated electrical activity of the heart, And each cell has its own electrical activity followed by its own contraction. So it's completely irregular and completely ineffective at pumping blood. Now, if it's just atrial fibrillation, you see kind of this squiggly line here. Instead of a P wave, we still have a normal QRS complex occurring, on a regular interval. But the atria are just kind of quivering, and they're not contributing to ventricular filling. This is usually not life-threatening because the atria contribute so little to the stroke volume. However, a big risk factor with atrial fibrillation, or a big risk, I should say, is that blood can kind of clot inside the atria because they're not really pumping efficiently. And then those blood clots can be thrown to the brain or through the coronary arteries to cause a heart attack or stroke. So most patients with atrial fibrillation have to be on some anti-coagulating blood or antiarrhythmics to try and control that fibrillation. Ventricular fibrillation is a life-threatening emergency immediately. So we have completely ineffective pumping action of the heart. This is greatly going to reduce the cardiac output. So we're not going to get enough blood to vital organs. So we may not get enough blood through the coronary arteries, and that can result in a heart attack. We're not getting enough blood to the brain, can result in a loss of consciousness. If this is not reversed shortly, then death will occur. So a way to reverse this is with defibrillation, and this is where we shock the heart and we hope to get all the fibers to go into repolarization, and then hopefully the SA node will then take over again. Okay, finally I'm going to talk about AV blocks. This is the only blocks I'm going to talk about. But this is where we have a block in transmission through the AV junctional tissue. So we have a block from getting from the atria to the ventricles through that conduction system. And this can be caused by scar tissue in the conduction system, such as from a previous myocardial infarction. We can have increased vagal tone, which can lead to first-degree block. Drugs, toxicity would be another cause. Okay, so let's describe the different types of AV block. First degree, we just have a prolonged delay in the AV node, and we see just a longer interval. I think this is shown here. So first degree block, if we measured the PR or PQ interval, we just see it's longer than what is expected or predicted. Second degree block, we have a prolonged delay, which results in a missed ventricular contraction some of the time. And this can be in like a 2-to-1 or to 3-to-1 pattern. Okay, so for instance here we have a P wave, QRS, P wave, no QRS, P wave, QRS, P wave, no QRS, P wave, QRS, and so forth. So this is second degree block described by a 2-to-1, 2 P waves to every QRS complex. Okay, and then finally third degree block, we have absolutely no transmission through the AV node. So the ventricles, remember the AV node will let me start over. The third degree, we have absolutely no transmission through the AV node. So that stimulus that started in the SA node is not getting through to depolarize the ventricles. Now, after a period of time, the ventricles can contract spontaneously on their own, but its spontaneous rate of depolarization is much slower, about 30 to 45 beats per minute. So with total, this is called third degree block or total heart block. The atria are contracting on their own, the ventricles are contracting on their own at a much slower rate. Because this rate is so slow, the cardiac output is severely reduced. So this is a life-threatening condition that will require a pacemaker. Okay, and here we see the third degree block. We have some P waves. So they're going off at their own regular interval, and then the QRS complexes are really spread out as the ventricles are beating independently and not being stimulated by that wave of depolarization from the SA node. Okay, and then finally, cardiac arrest is when we have sudden cessation of all heart activity and failure of the heart to pump blood, aka flatline. This can be caused by cardiac diseases. In fact, it's usually caused by ventricular tachycardia. You can see it with coronary artery disease. We're not getting enough oxygen to the heart attack, cardiomyopathy, valvular disease, long QT syndromes. There can also be other causes, such as potassium imbalance, drug toxicity, if you get electrical shock, respiratory arrest, or a blow to the heart. Cardiomyopathies. These are disorders of the myocardium, which leads to problem in myocardial performance, which can be mechanical, causing heart failure, or electrical, causing arrhythmias. These disorders are classified as primary, those are which are confined to the myocardium, or secondary, that are associated with other diseases or conditions. The primaries are further subdivided by etiology, being genetic or acquired cardiomyopathies. Here's an example of a genetic cardiomyopathy, is hypertrophic cardiomyopathy. And this is a genetic defect in some myocardial contractile proteins. This leads to severe left ventricular hypertrophy, and we have disproportionate thickening of the ventricular septum, abnormal filling, and cardiac arrhythmias. This can result in sudden cardiac death if this ventricular septum blocks the outflow into the aorta. Some of the, or it can cause, sudden cardiac arrhythmias. This symptoms include shortness of breath, chest pain in the absence of coronary artery disease, syncope or fainting post-exercise is a risk factor. So often young people that pass out right after exercise might be looked at for this condition. So with this condition, you need more oxygen, and the heart performs less efficiently. This causes the patient to be more prone to heart failure and sudden cardiac death with exertion. This is the most common cause of sudden cardiac death in young athletes. In dilated cardiomyopathy, the heart is dilated and stretched. So the ventricular, the heart muscle in general is weak. It doesn't pump normally. It's kind of stretched out and dilated. Some etiologies, it could be genetic, alcoholism, infectious, chemotherapy. Manifestations, we get signs of heart failure, blood stasis in the heart because it's not pumping it out efficiently, and thrombus formation, mitral valve regurgitation, and arrhythmias. Restrictive cardiomyopathy is where the ventricles are really stiff and non-compliant, and they're not very able to fill with blood between heartbeats. They just can't expand. And this can be caused by radiation fibrosis, cancerous tumors, sarcoidosis, or it could be idiopathic. The manifestations of this are going to look like constrictive pericarditis. And then myocarditis refers to inflammation of the heart, and this can range from asymptomatic with full recovery to acute onset with heart failure or sudden death caused by arrhythmias. And myocarditis can be caused by a viral infection or lupus. Drug hypersensitivity are some examples. Okay, so now we're going to look at disorders of the endocardium. Remember, the endocardium is the innermost layer of the heart, and it makes up the heart valves. So let's start with looking at infective endocarditis. This is when we have infection of the heart valves characterized by colonization with bacteria and the formation of these vegetations on the heart valve cusps. how do we get this? The organism gains access to the circulatory system and damaged endocardial surface. So if you have like a defective heart valve, that's going to pose the greatest risk. So if you have a congenital, say, defective heart valve, then you get exposed to bacteria in your blood, then that can colonize that defective heart valve. And this can occur even with dental or surgical procedures. So with just the dental scraping of the teeth, bacteria can get into the blood. And then if you have defective heart valves, they can colonize those heart valves and lead to endocarditis. And that's why patients with known defective heart valves, like they have a severe heart murmur, will take, or even not so severe, but they have a heart murmur, they'll take prophylactic antibiotics before they get their teeth cleaned. Now, you can also not have defective heart valves and get endocarditis if you get exposed to extremely strong, virulent bacteria that gets in your blood. But the people that are at most risk are those with defective heart valves. However, other host factors, even if you have normal heart valves, can put you at greater risk. For instance, if you have immunodeficiency, neutropenia, diabetes mellitus, alcoholic, and IV drug users are more at risk. Okay, so you have these vegetative lesions on the heart valve. They're made up of the microbes as well as fibrin, platelets, and blood cells. The aortic valve and the mitral valve, the valves on the left side of the heart, are most affected. These vegetations can cut off and break off and cause septic emboli, creating other problems within the heart or within the body. It can also lead to valve destruction, and then it can lead to dysfunction of the valve, including like aortic or mitral valve regurgitation. Manifestations include fever and signs of systemic infection, a new heart murmur or a change in an old heart murmur, small hemorrhages due to emboli in small vessels of the skin and nail bed, mucous membranes, we can see dark red lines under the nails, cough, shortness of breath. And as I mentioned, we want to give prophylactic antibodies in patients. Rheumatic fever and rheumatic heart disease are caused by an immune-mediated inflammatory disorder that involves the heart, skin, and connective tissue. Now I want to make it clear that although it occurs after an untreated strep infection by group A beta hemolytic streptococca, it is not a direct result from the bacteria, rather is a direct result from the immune response. Rheumatic heart disease is the cardiac manifestations after rheumatic fever. So we get the untreated strep infection. The immune system kind of ends up causing an inflammatory response, particularly in the heart. So it causes inflammation of the endocardium, endocarditis, myocardium, myocarditis, and pericardium, pericarditis. Now the myocarditis and pericarditis usually go away, but we get damage to the heart valves that is permanent, and that's rheumatic heart disease. So these valves, leaflets can fuse together and cause stenosis, or the valves can get distorted. There can be vegetations on the valve, so they do not close properly, and that can cause regurgitation. Once again, the most commonly affected heart valves are on the left side, the mitral and the aortic valves. Okay, so let's talk about valve dysfunction. So it can be congenital, you're born with it, or it can be acquired, say from endocarditis or rheumatic heart disease. Either way, it involves alterations of the heart valves that can lead to either stenosis, or incompetent or some combination of the two. In either case, this is going to result in abnormal blood flow through the defective valves, and this can be detected as a heart murmur. Stenosis is when the valve is constricted or narrowed. So the valve won't open all the way, and it's harder to force blood through it when it should be open. An incompetent valve, the cusps fail to close all the way, and then blood is allowed to regurgitate back in the direction from which it came. So it leaks back when it should be closed. Valve dysfunction tends to affect the left heart valves more than the right. So when will you hear the murmur? If a valve is stenotic, you'll hear a murmur of blood shooting through the constricted opening when the valve is open. Now, if this is an AV valve, such as the mitral valve or the tricuspid valve, the valve is open during ventricular diastole, or filling of the ventricles. So you would hear the heart murmur during ventricular diastole. If it's the aortic valve or the pulmonic valve, if the valve is stenotic, you would hear it during ventricular systole, when the heart is contracting and pumping blood into the aorta and pulmonary artery. On the other hand, if the valve is incompetent, you'll hear a murmur of blood leaking back through when the valve should be closed. For the AV valves, those valves should be closed during ventricular systole. And for the aortic and pulmonic valves, those valves should be closed during ventricular diastole. Okay, so with mitral valve stenosis, you're going to have incomplete opening of the mitral valve here between the left atrium and the left ventricle during ventricular diastole, and that's going to lead to left atrial distension because less blood is able to go through the valve, so the atrium gets overfilled, and it leads to impaired filling of the left ventricle because less blood is going into the ventricle to fill it. So the left atrium becomes dilated. This is going to lead to an increase in left atrial pressure. Over time, this blood can back up into the pulmonary veins and then into the pulmonary system, causing pulmonary congestion. Mitral valve stenosis is usually a result of rheumatic fever. Mitral valve regurgitation is when we have incomplete closure of the mitral valve. So during ventricular systole, blood goes out the aorta, and some of that blood goes back, regurgitates through that incompetent mitral valve into the atrium. This is going to lead to an increase in left ventricular end-diastolic volume. And then we're going to get left ventricular hypertrophy to kind of compensate. And that's going to help to maintain stroke volume, but over time, that increases the work and the oxygen needs of the heart. So this condition can be asymptomatic for many years, but as it progresses, eventually left ventricular function becomes impaired, stroke volume decreases, and left atrial pressure increases. And that increase in left atrial pressure leads to pulmonary congestion and the associated symptoms associated with that. And there's a few causes such as endocarditis, rheumatic heart disease, rupture of the papillary muscles or chordotendae, as in one of our case studies after a myocardial infarction, or mitral valve prolapse. Mitral valve prolapse is the most common valve disorder in the U.S. and affects women more than men. These cuffs are kind of enlarged and thickened, and they may cause mitral regurgitation. Most often they're asymptomatic, but they can be heard with the stethoscope, and most people don't have any physical limitations. If it's severe enough, those people may be taking antibiotics to prevent getting infection of heart valves, infectious endocarditis. Okay, aortic stenosis is when we have narrowing of the aortic valve, and that's going to make it a lot harder to pump blood out of the left ventricle during ventricular systole. It develops gradually, and over time the left ventricular can tend to hypertrophy in order to compensate. But over time, that increased work of the heart can eventually cause it to fail. This is usually caused by congenital malformations, or the acquired case is normal wear and tear and calcification of the valve. Aortic valve regurgitation occurs when we have an incompetent aortic valve that allows blood to backflow from the aorta into the ventricle during ventricular diastole. And this is going to lead to an increase in volume and pressure within the left ventricle, causing volume overload. Over time, this failure can lead to backup congestion into the pulmonary system and the associated symptoms. And this can be caused by rheumatic heart disease, congenital abnormalities, endocarditis, and so forth. Last but not least, we're going to talk about congenital heart defects. These are structural defects that develop during fetal life. They are the most common form of structural birth defects. And these defects can be classified based on tissue oxygenation. Are they cyanotic? The tissues receive blood that's not fully oxygenated, in other words, blood that has bypassed the lung. Or acyanotic defects. The tissue receives blood that is fully oxygenated, but maybe it's not getting as much blood because there's a defect. It can also be classified based on hemodynamic alterations or shunts. So let's take a look at shunts. So a shunt is an opening or connection that lets blood move from one side of the circulation to the other, from the left to the right or the right to the left. Most shunts occur in the heart and move blood either from the left to the right or from the right to the left. But because the left side is stronger, if there's a shunt, blood is usually pushed from the left to the right side. Now, shunts before birth are normal. And there's a couple of shunts that we have before birth that help to bypass the lungs. One is the foramen ovale. So remember, the fetus is getting oxygen from the placenta and not from its own lungs. So we have a couple of ways to bypass the lungs. So because of the hypoxia within the lungs, the pulmonary blood vessels are constricted, and that dramatically increases the pressure in the pulmonary vasculature. And this is going to help encourage blood to move from the right side to the left side instead of the other way around. So the foramen ovale is an opening between the right ventricle and the left ventricle. So blood returning to the fetal right atrium, because the pressure in the fetal circulation is greater on the right side than the left. Some of that blood gets shunted to the left atrium, bypassing the lungs, and then it goes into the left ventricle and out the aorta. Some of that blood does go into the right ventricle and gets pumped to the lungs, okay, or at least to the pulmonary artery. There's another connection between the pulmonary artery and the aorta, and that's called the ductus arteriosus. Once again, the pressures are greater on the pulmonary side than the systemic side in the fetal circulation, so blood is shunted from the pulmonary artery to the aorta, once again bypassing the lungs and going to the body. So in the fetal circulation, the shunts are right to left, okay? But after birth, when the lungs become oxygenated, then the pulmonary blood vessels dilate, and that's going to dramatically decrease the pulmonary vascular resistance. In fact, it decreases to become 1/5 that of the systemic resistance and pressure. So if those shunts were still open, this would cause the shunts to be left to right. Okay, so those shunts after birth are not normal though. So most of those shunts, if there were a shunt after birth, would be left to right. So this is blood that would go into the systemic circulation, instead goes back into the pulmonary circulation, gets repumped again. So extra blood going back into the pulmonary circulation is going to increase the workload of the right side of the heart. However, it's considered an acyanotic defect because the blood is not bypassing the lungs. However, the kids may be cyanotic because, for example, they're going to have a low cardiac output because blood from the left ventricle is going back into the lungs, so less output out the left ventricle. A right to left shunt is when the deoxygenated blood, so blood that hasn't seen the lungs yet, moves from the right side of the heart to the left side of the heart, and it gets ejected into the systemic circulation without being oxygenated, causing a mixing of deoxygenated and oxygenated blood. So this would be considered a cyanotic defect because the tissues are receiving blood that is not fully oxygenated. So patent ductus arteriosus. This is when we have failure of that ductus between the aorta and the pulmonary artery to close after birth. Now, an open, so PDA is a patent ductus or open ductus arteriosus, is going to allow blood to be shunted from the aorta to the pulmonary artery. Now, once again, it is going to be a left to right aorta to pulmonary artery shunt because the pressures in the left side in the systemic circulation are greater than the pressures in the right side. But we're going to end up with more blood than usual in the pulmonary circulation, so this can lead to pulmonary hypertension, put strain on the right heart, and right heart failure. Septal defects. These are the most common type of birth defect, particularly that ventricular septal defect. So the septal defects are an abnormal opening either between the atria, as in an atrial septal defect, or between the ventricle and the ventral septal defect. Here the shunting of blood is normally going to be from the left side of the heart to the right side of the heart, left side of the heart to the right side of the heart. So once again, it's acyanotic because oxygenated blood is just getting repumped to the lungs. If the defect is small, there's just a small increase in pulmonary blood flow and it may not even be detected. With medium defects, we have a larger shunting, but still probably under low pressure, and we don't really develop pulmonary hypertension. With large defects, however, that are untreated, this can lead to an increase in pulmonary vascular resistance because of the extra blood. And it could lead to pulmonary hypertension, which could eventually switch the shunt, so then it becomes right to left, because now the pressures are greater in the pulmonary side due to all the extra blood, and then it would be considered a cyanotic defect. Okay, pulmonary stenosis. This is where we have narrowing of the pulmonary outflow tract. This can be due to abnormal thickening of the valve leaflets, a narrowing of the valve, or the valve might not even be formed. That's a type of congenital defect. This is going to force the right heart to pump harder than normal to try and overcome that obstruction. This can be asymptomatic if mild or moderate, but can lead to pulmonary hypertension and congestive heart failure if it is severe. Okay, so now we're going to look at a couple cyanotic defects. One is tetralogy of Fallot. And in this syndrome, we have 4 defects that occur together that's going to cause a cyanotic defect. It's going to cause a right to left shunt. First of all, we have a ventral septal defect, an opening between the left and right ventricle. Then we have the aorta right over the ventral septal defect. Then we have pulmonary valve stenosis, which is going to really restrict the blood flow into the lungs. And then right ventricular hypertrophy, that ventricle is going to thicken to try and get blood into the pulmonary artery. What happens is it's going to cause a right to left shunt because the pressures are higher on the right side due to that stenosis and ventricular hypertrophy. That's going to push blood from the right side into the left side, and then with the aorta sitting right over the ventricle, blood's going to go out the aorta and be pumped. Deoxygenated blood is going to be pumped into the circulation. Okay, last but not least, we have transposition of the great arteries. And this is where the aorta comes out of the right ventricle, which pumps blood into the body, and the pulmonary artery comes out of the left ventricle, which pumps blood to the lungs. So this is going to result in two completely separate parallel circulations. We're going to have unoxygenated blood that continuously circulates the systemic circulation, and oxygenated blood that circulates continuously through the pulmonary circulation. Now, in order to survive outside of the uterus, this is going to require some communication between these circuits. Look at that in some of these diagrams coming up. Okay, so in this diagram, we want to show how this would look with a ventral septal defect, a patent ductus, and tetralogy of Fallot. So in the normal, this is my little flow chart here, blood from the body, deoxygenated blood from the body, goes to the right heart pumps it to the lungs pumps it to the left heart, and then the left heart pumps it out the aorta to the body. Okay, with a ventral septal defect, I've drawn a left to right shunt showing oxygenated blood. So blood, deoxygenated blood from the body goes to the right heart, gets pumped out the pulmonary through the pulmonary artery to the lungs, gets oxygenated, goes to the left heart, and then when the left heart contracts, oxygenated blood goes to the body, but some of that oxygenated blood goes back to the right heart to get re-pumped into the lungs again. With a patent ductus arteriosus, that connection is between the aorta and the pulmonary artery. So blood from the right heart, deoxygenated, gets pumped to the lungs via the pulmonary artery, goes via the pulmonary veins to the left heart, and then when the left heart pumps blood into the aorta, some of that blood goes back to the pulmonary artery through the open ductus, while the rest of the blood goes to the body. And then finally, with tetralogy, we now have a right to left shunt because we have pulmonary hypertension. So blood from the deoxygenated blood from the right heart, when it pumps, some of that blood goes to the lungs and some of that goes to the left heart. The left heart pumps a mixed oxygenated and deoxygenated blood to the body. Okay, so how would this look with transposition of the great vessels? Well, I've shown that here. Okay, so with transposition we have two separate circulations. One that is O2 rich, so the left heart pumps blood out the pulmonary artery, which goes to the lungs, and blood returns via the pulmonary veins to the left heart. So note the veins don't change, just the corresponding arteries. The other circulation, we have oxygen poor blood returning to the right heart via the veins, and then the right heart pumps that deoxygenated blood to the body. So two separate circulations. Okay, now survival would not be possible without medical intervention and without some other shunts that are going to allow some mixing of these of the blood between these two separate circulations. So with this defect, the patent ductus, the ductus would stay open. The ductus would stay open, allowing some mixing of blood between the aorta and the pulmonary artery. And the foramen ovale would remain open, allowing some mixing between the right heart and the left heart. And then I do know somebody that had a child that had this, and they performed surgery at 6 days, and they just switched the aorta and pulmonary artery, and this child is now, I think, about 12 or so, and has mild pulmonary hypertension, no other limitations. So, pretty cool. All right, that's all. We'll see you for topic 3. For part 3.